Today we're going to be talking about the October EMS summary. The main discussion was death telling and giving bad news, and we also talked a little bit about traumatic arrest and what that looks like. So, some main points from this. First off, when we walk in, the most common scenario for this is going to be probably cardiac arrest. That's the most common time that we have to give bad news or do death telling. There's obviously other bad situations, but that's one of the biggest ones and probably the most common one that we deal with. So right out of the gate, when you're gonna have to have a difficult conversation with the family members or friends about their loved one that's not doing well, you want to gain their trust early on. And how do we do that? You're just meeting them for the first time, so right from the time we walk in the door and start doing our stuff, we need to try to gain their trust. And it's not gaming the system to gain their trust. It's simply doing our job well and being professional. We know what we're doing when we're on scene, so we have all our equipment. Our communication is good. We look professional. We carry ourselves well. We do all the things that we need to do, right? So you're establishing yourself that yes, we know what we're doing, and we're doing the thing that we always do, right? A lot of families or friends want you to rush to the hospital, and we know that doesn't work so well with cardiac arrest. Like, we stay in play and put all the pieces together and see how things shake out. We don't just run off to the hospital. So if that's their sentiment, you need to make sure you're looking professional and doing good work so they understand, like, yep, these guys look like they know what they're doing. And they can be confident when you come to them and say, hey, we're doing all the things and it's not going so well. All right, so that right out of the gate, we gotta be confident in what we're doing. I would be careful about saying the hospital doesn't have anything to offer, and we talked about this a little bit at training. The hospital has some very specific things to say if you use the words the hospital has nothing to offer, that's not entirely true. Again, we talked about specific situations where there's things that need to get fixed, and we also talked about the fact that if you're in those situations, like a STEMI, like the patient needs a cath lab. Like, we're not leaving a STEMI on scene if we know we have something actionable that the cath lab could fix, right? So generally speaking, we're not going to leave that patient, and we're going to try to get down the road. Things like ECMO in certain situations, right? So there are some things, but generally speaking, no. And your standard ACLS is ACLS, whether it's pre-hospital or in the ER, that's ACLS. So that is very much the same. So in that regard, there's not a whole lot that the ER can offer there. But again, there are specific situations. So, all right, so let's say you're working in cardiac arrest, things aren't going well. Giving a warning shot to the family is a good idea. So that first conversation ideally would not be when you're at the very end and say, oh, we're all done. It would be, hey, things aren't looking good. And you can try to get some more information from the family at that time, or hopefully you've had some conversations with the family. But giving a warning shot that this isn't going well is a good idea early on. And then in relation to that, at about the same time, a succinct summary of what's going on makes sense. And sometimes I get too much into the weeds when I talk with families like this. I had a cardiac arrest 2 nights ago to start my shift, so I had to do this very thing. I walked into the family room to meet the wife, never met her before, tried to give her a warning shot that, hey, things aren't going well, your husband's in cardiac arrest. And then the language around that, I think, needs to be very simple. So they're not breathing on their own, their heart's not beating. Like, just a couple of things there, right? Like, not way into the weeds. And then what are we doing? Medications, breathing, compressions, and shocks. I think keeping those big 4 categories is pretty simple. Patients don't need to know that it's amiodarone and epinephrine for your meds. They don't need to know that you drilled the IO versus you put an IV in their arm. They don't need to know that you're using a BVM and you use a 7.5 tube, or you're using an iGel. Just medications, breathing, we're doing compressions, or the machine's doing the compressions, and we're giving shocks as needed, right? So just keep it simple. The patient's not doing these things, not breathing, their heart's not beating, we're doing these things. Right? Keep that very simple. Don't get way bogged down in the weeds. The average family is just not going to understand all the medical lingo. And again, in such an emotional setting, as we talked about, it's very hard to cognitively process information when you're emotional. So keep it very simple. So it helps sometimes, if you can, to have a couple conversations like this before the end. Like I did with this lady the other night. I asked if she wanted to be there when we turn everything off. As the case progressed, the husband wasn't getting better. We weren't getting any ground. We didn't have anything we could obviously fix. I asked the room, does anybody have any ideas, to make sure that we're all on the same page. We're looking with ultrasound to see what's going on. We're doing pulse checks, doing all our normal ACLS. And again, I poll the room. Like, I don't want to be the guys like who missed something obvious. So I have a pharmacist there. I have nurses there. So I asked the room, anybody else have any ideas? And then when we get to the point, like, yeah, we've been doing this for so long, we don't have any other options. Nobody has ideas. There's nothing else that we can readily fix. Then I go back again to the family. In this case, she wanted to come with when we turned everything off. So if family wants to do that, that's perfectly reasonable. Sometimes it helps them process. Sometimes they don't want to see all of that. If they do see that, I think it's easier. Like they get that the patient is dead or died. But if they're not right next to the patient when that happens, and you go back and tell them, you need to be very precise and concise and use words like the patient died, the patient is dead. Don't use things like the patient passed over, the patient moved on, the patient's in a better place. There's all kinds of ways to say dead and died that are not succinct, so make sure you're clear so there's no confusion about that. I'd be very cautious about saying the words, I know how you feel, I understand what you're going through. Saying things like that, you're not that patient, and you're not the family member, and you don't have the same relationship to that family member that they did. So even if you lost your loved one, your mom, your dad, you lost a loved one tragically, or you have some idea about what they might be going through, I'd be very cautious about that. People say it and they mean well, but you could also have family members snap back at you and challenge you on that. Like, how do you know how I feel? Like, have you lost a loved one? Did you lose your dad by cardiac arrest? Then you're stuck, right? And then you're not going to gain any trust with the patient, or with the family. So be cautious saying those things. I shared that my dad died of dementia, so I have some common ground when I talk to families with patients with dementia, but their relationship with their loved one and my relationship with my dad are not the same. So you can't be too specific. You can generalize, you can acknowledge things like, this is really hard, this sucks, I know how frustrating this can be, I know how frustrating the medical system can be, I know there's not always great answers. Those things are true, universally true, right? So sharing those things makes sense, but being very specific about exactly how they feel, that one, I would just be careful with that one. Involve the police when you're on scene, because if you're leaving a patient, they're going to be the ones that have to deal with that. So if they can be involved in these conversations earlier on when you're talking with the family, that would be helpful, so that you're all saying the same thing. It gets difficult if people are delivering different messages to the family. We shouldn't be doing that. It causes confusion. And we talked about how in the medical system, if somebody early on says something to a patient or a family, they very much latch onto that and expect that thing to happen. So those things that maybe you mean well and you're saying something that could happen down the road, the family may latch onto that, and now it's an expectation, and then they're very disappointed. They're frustrated with the medical system. They're distrustful of the medical system because somebody said this thing not knowing any better, and at the end of the day, that thing is not actually happening. So a similar thing applies here. So make sure that you involve PD when you can. Make sure that you're all on the same page and saying the same thing to the patient and to the family. I also take a moment of silence when people die. So in this case, after we turn the thing off, the wife is sitting by the bed, we turn the monitors off so there's no beeping, stop breathing for the patient, turn off the Lucas device. I just pause, bow my head, fold my hands like this, take a moment of silence. I don't have an exact time frame, just a moment like you would. And then to end it, I just lift my head up and say, thank you everyone for your help, or something, thank you, something just simple. And it's sort of a way that we can all move on. It pauses that we are acknowledging this human life that we just lost, and then also gives people a chance to then move on from there. So when I say thank you, then usually people can go about cleaning things up and going on to next things. So I'd encourage you to give that a shot if you're not already doing it. Last couple things. This is a learned skill. Just like the other skills you have, even if you're not good at it now, you can get better at it. Watch the people on your shift that are good at it. There's a PDF that's attached here that we talked about, so look over some of those things. There's some mnemonics for the words to use and how you're setting this up. The other thing I said, and we've talked about this before in other cases, is understanding the downstream effects of where something is going. So when you're using language to talk about maybe somebody who doesn't die, but things are not looking good, so maybe a resuscitated cardiac arrest that you got back, you're going to transport, but that patient is still critically ill. Be careful about what you're saying about downstream, about what's going to happen for that patient, because they may rearrest between, say you get ROSC on scene, and now you tell the family we'll meet you at the hospital and everything's going to be fine. Well, that's maybe not true. And then the patient rearrests en route. They're going to you said everything was fine, and you knew perfectly well the patient could rearrest because they're critically ill, but you didn't convey that to the family, and now they're wondering what happened. You said this thing and this thing didn't happen. So understanding the downstream effects and being careful about what you say is going to happen for patients who are critically ill is important. Lastly, we talked about traumatic arrests. We're going to take a look at those protocols and see if we need to adjust that. We talked about how the outcomes are generally very poor with both blunt and penetrating trauma and traumatic arrest, and how much we need to be doing with those on scene. I know we don't have them very often, but we're going to take a look at that protocol and see if we need to make some adjustments.